Yes.
So, is, do we have to write a paper with them?
With what?
With the little projects that we have to do?
Your homework assignments?
Yeah.
There's a rubric on there.
Okay, so we'll
I
follow
think
that.
it says, I can't think
It
of it
says
right now.
1 page, 1 or 2 paragraphs.
1 to 2 paragraphs,
Okay.
maximum 1 page.
And then for both of them, for the visual, can we do a poster board for both?
You can, at least for one of them, you have to do a poster board.
Okay.
Yeah.
So both of them can.
Mm-hmm.
Okay.
Yes.
Does it matter which one we do the poster board?
No, whichever one you want. Sometimes the subject that I gave you might not work good on a poster board. It might just be like writing, so that's why I kind of let you choose. But eventually we will, whichever classroom we end up in, we'll put all the poster boards around the room. So you guys can visualize them and kind of bounce off of them. It's a good kind of visual for you.
Okay.
Yeah. All right, I know we have at least one presentation today, but I just want to talk about just a couple things. Next class, you've got your first mock, right? It's going to be in the assessment center. So everyone will be in the assessment center. The start time is 9 a.m. Okay? So be there at 9 a.m. Be there on time because your test is very long. So we have a reservation for a block of time. So if you get there late, the block does not extend. Okay? Everybody hear that?
Building and room number?
Is it E building?
It's above Subway.
Okay, second floor E building.
So it's just a testing center?
Yeah, it's called the assessment center. Yep, the assessment center.
When is it?
So it starts at 9 a.m. Your block is kind of measured out. You have 1 minute per question. It's 200 questions. We won't be reviewing face to face. I'll probably set a time that we can meet later on in the week and talk about any questions. I will leave your exam open for you to review it, okay? All right, so once you take it, you can review it all week. And then if you have any questions of like discrepancies or anything like that, email them to me. And then I'll post a session where we're gonna meet live just to review it because we just don't have enough time in class to do it all. Yes?
So the mock registry test complete?
Yep, complete mock. Again, I will try to upload, or maybe I'll give you guys a copy of it so you can write on it. The next class that you actually come in, so not next class for your mock, but the next class, I will give you a printout of how I've subdivided the categories for each question so you can go through and find your weak area. So that way you can really target in on what you need to put a lot of work into. It's probably gonna be procedures for almost everybody though, because it's just so much information.
Will it show the correct answer?
Yes,
It will?
yes. Yep, it will tell you the correct answer. You can review it all week, and then we will meet for a live session for review.
And all we'll need that day is what?
Calculator.
Calculator?
Yes, bring a calculator. I'm going to allow you to bring your own calculator in.
Does it have one on there too?
It does have one, and I was researching some stuff for ARRT this week. You can request a hand calculator if you want to for your exam, for the Pearson View testing centers. So you can use the computer calculator if you want, but they can also provide you with a basic 5 function if you want that, if that works better for you. So if you want to kind of purchase one of those to get used to doing your questions like that, you can. I would advise that. Or if you're comfortable using the computer calculator, use that. Are we good? Good on that? Don't forget your lane questions are due next class. So I'm just gonna create a link on Canvas. So 50 questions from the patient care section. It's gonna be due at 8:30 on Wednesday. 8:30 a.m. on Wednesday.
And did you say something about writing them out? Or
You don't
just
have to write them out.
answer?
You can submit them however you want to. Somebody was asking me, do I have any kind of advice on which questions to answer or which ones to skip? I would focus on the questions that you have the most difficulty answering. Most people struggle with those 2 and 3 part questions. So if you want to kind of go through the patient care section, and if you see a more difficult question or maybe a word question kind of intimidates you, I would go for that one. I'm not going to grade you on rightness or wrongness or correctness or incorrectness. I'm just going to give you a completion grade because all the answers are in that Lang book. So I don't care if you got the answer right. The answers are in there. I hope that you know what the answer is, and I do want you to go through and see what you got right or wrong, but I just want you attempting questions. Okay, so 50 of your choice. You can take a picture of your book, you can write question 1 through 50 and write your answers, however you want to submit it. Okay. Take out a piece of paper for me. It could be a small scratch piece of paper. We forgot to do this on the first day, so I just want to do it now. At your pinning ceremony, there's a couple of awards that will be given out. There's an MVP award, which I've just got to go back and view some of your grades. There's a clinical performer award that I always give out. And the other one I give out is a peer award. But I let you guys choose who gets the peer award. So the peer award is based off of somebody who maybe overcame something or really works well at organizing study groups for your class or maybe helps push you through. It's just somebody that you can go to and who is a good peer. So it's called a peer award. So I want you to write down a nomination, so somebody that you would like to receive this.
Wait, what are the topics again?
It's the only one that you're voting on is a peer award.
Oh, okay.
Yep, a peer award. So I want you to write the name down, and I want you to write down like a sentence or two, or a couple words. Why are you nominating this person? So it's a majority vote, so I'll go through all of them, and whoever gets the award, I will write their name down and all the comments or sentences that you guys wrote down at the pinning ceremony. Okay? Mia, do you have the Kettering list?
Yes, I did.
Okay.
Do you want me to just email it to you?
Yes, thank you. Everybody on this list who wants to be on it for Kettering, sign up. Okay, this is your last call. Mia has the list, I'm sorry.
Yeah, you did that like through me, right?
Yeah, I have everyone.
Can you just call out the names to make sure?
Yeah. Madison, Cassidy, Kieran, Sienna, Kristen, Heather, Marissa, Ethan, Adrienne, Carrie, Braylon, Jenny, Jesse, both Nicole's, Tara, Ashley, Audrey, Jasmine, Natasha, Megan, Kat, Cheryl, Shelley, and Shannon.
The last word.
Yeah.
Okay.
Good?
Thank you.
All right, if your name's not on that list, I don't have a name for you for your Kettering seminar, okay? All right, everybody good? All right. All right, when you've done your peer award nomination, you can just fold your paper and pass it forward. And then we'll go into patient care. Got my new Kettering book, guys. I'm trying to teach out of it today.
Are they updated every year?
They update it every time there's new test specifications.
So like,
Every 4.
so like now, that one's updated.
Yeah, this one's a brand new one.
Do they typically change a lot or just?
Normally what happens is they pull out, just a couple things or maybe change the wording or verbiage. Like I know that they pulled 2 procedures out for this new exam. And it's,
Do you know which ones? I can't remember.
I can't remember. I wanna say it's like TMJ, something like that.
And I had one more question. For this stuff that we're going over, do you already, like, you go over it yourself too, right? Like, you have a list? Can I, so like, after we go over this today, can I take a picture of yours that you have?
Today, I'm just gonna use this Kettering book, because this is the first day I have it. You can take a picture of this. It's the same thing.
Even though it's a little bit older? Yeah.
I'm sure it's the same thing for patient care, yeah.
You're doing my call.
Thank you. All right, all right.
I like this outfit.
Thank you. All right, remember, now is not the time to get a new job. Now is not the time to move anywhere. Now is not the time to focus on anything else except for your registry, okay? Put in the work. It's going to be worth it. put in the work now so you don't have to study for a month when you graduate, right? This is why we're doing this. All right, so let's start out in patient care, section E. I am just gonna use this new Kettering book that I got. I told you guys that I ordered it. The online lecture is only a one-time person use, so I'm not gonna give you guys my login because it won't let you log on for multiple computers at one time. This is the same book that you will get at the seminar. So I'm just feeding through it now. I'm gonna start using it to make sure the information is accurate. I compared this section to my notes. Everything was basically the same. This is very detailed though. Very, very detailed. But don't purchase this if you don't have it yet, because at the seminar you will get this. You will also get a workbook. It's a skinny kind of workbook that they give you. It's a fill in the blank kind of thing, or diagrams, anatomy, stuff like that. And then you also get a mock included in that. So if you want to take one more mock after you take my 4 and you're dead, that's a good option too, right? All right, so let's go ahead and start from the top. So we're going to start in infection control, chain of infection, or cycle of infection. What do you guys have down here for the first section?
And the pathogen?
Do you have anything for chain of infection or cycle of infection? Do you guys have any? Go ahead.
I have, the factors in infection, transmission / cycle. There were 6 of them.
Mm-hmm.
One is infectious organism / pathogen.
Good.
2, a reservoir of infection and environment for pathogen to live and multiply.
Good.
So that's, I think,
Portal of exit.
I said something about like the incubation period or something.
Mm-hmm.
3, a portal of exit from the reservoir. 4, a means of transmission. 5, a susceptible host. 6, a portal of entry into the susceptible new host.
Okay, good. So you want to know that cycle of infection. I would know the order for sure. So infectious agent, reservoir, portal of exit, mode of transmission, portal of entry, and a susceptible host. I would for sure know the order of that. And I would also know how can you break the chain. So how do you break the chain?
Take one out.
How?
Washing hands.
Washing your hands. How do you break the chain or the cycle of infection? Washing your hands. Hand washing. Most important thing to prevent diseases and infection control as a rad tech. All right, pathogen. What do we have for pathogen?
Bacteria, virus, or other natural organism that causes disease.
Good. Bacterial, virus, or any kind of fungal infectious agent producing a disease. Good. Reservoir.
Dirty surfaces, equipment, people, water, animals, insects.
Good. Anything that a pathogenic organism can live on and spread or grow. So anything that it can live and grow in. It could be water, a human being, an animal, food, anything like that. Okay, portal of exit.
Site from where microorganisms leave the host to enter another host and cause disease infection.
Good. Where they're exiting the reservoir. So where it's going out to kill you, right? Yes.
And then for examples of that, I had urine, feces, blood, respiratory droplets, and contaminated solutions.
Excretions, right? Bodily fluid excretions is a good example of that in our field. Good. All right. Mode of transmission. We should have some subsections here. So we have direct and indirect. So let's talk about direct first.
Host is touched by infected person. So like droplets, like staph or strep infections.
Good. So we have direct, and then we have droplet and direct contact. So if it is a droplet, it is considered direct. So what is the difference between droplet and airborne? How do we distinguish those two? Droplet what?
Can travel 3 feet.
Good. Okay, droplet can travel 3 feet. Yes.
Airborne stays suspended in the air for long periods of time. It's
Good.
like aerosol.
Exactly. Airborne is suspended in the air for for longer periods of time. So think about airborne like an aerosol mist. So like Febreze. So you're spraying it, it's very tiny. You can smell it, but you don't necessarily see it, right? Droplet is large. So you cough, sputum comes out, right? Mucus comes out. You sneeze, spit, droplet. So it's coming out of your mouth and it's larger. If we're talking about airborne, small aerosols, okay, suspended in the air, so they can hang out. It's not just exiting someone's body. I'm walking by, I'm breathing, and if it's an airborne transmission, it's hanging out behind me, okay? So the next person who walks by is gonna breathe in the air and get infected. All right, so droplet direct, if it's inhaled. So they give you, or you talked about two types of infections that they could be with, and they give you an example of strep. So when you have strep, it's considered droplet. You're coughing, you're hacking. Those large droplets go directly from you to someone else. That's why it's direct. Okay, directly from you to someone else. I cough on somebody or I sneeze on someone. All right, so let's talk about indirect. Indirect. What do you guys have for this one? So it has airborne, vehicle-borne, which is fomite, or vector-borne, which is mechanical or biological. Mechanical and biological are usually not in the textbook. Did anybody find those? Okay. Let's talk about them. What are they? What's the difference between mechanical and biological vectors?
Oh, no, I didn't get the difference between those two.
So biological would be an animal or an insect carrying something that can.
Okay. What is the mechanical? What's the difference? Yes.
The mechanical is where, for instance, a fly just has contaminants on their body and it's present and they land on something and it's transferred that way, whereas biological, you're actually being bit by a tick
Good.
or a mosquito and they transfer that way.
Good, exactly. I don't know why they break it down like this on the registry because I never learned it like this either. But the way I think about it with my brain, biological is biting. So if something bites you, it's biological, right? If it's mechanical, think of it like a carrier. Like she mentioned, a fly. So we all know that flies are gross, right? They carry a bunch of gross stuff. They just land on things and carry it. But it's not actually biting you, okay? So that's the way that I distinguish them at least. Let's go back and talk about airborne. We talked about that already. Everybody good on airborne? Everybody feel good on that one? Okay, so let's talk about vehicle-borne or fomite. What do you guys have written down?
Formites are objects that have come in contact with the pathogenic organisms, so like the X-ray table or like our hands.
Good. So fomite is some kind of vehicle. I like to think about it like this because oftentimes I'm sick because I have little kids. So here's my fomite, I'm passing it to you, right? Paper. So something that's infected and something that can carry it. So it carries it. It could be a coffee cup. We're sharing an item. It could be a pencil. Don't share pencils. Don't share pens right now, right? So anything that is a vehicle is considered to be a fomite. Next, let's see. We already went over vector-borne. Everybody good on mechanical versus biological? So biological bite, mechanical just a carrier. Portal of entry. What do we have?
Open skin, respiratory tract, mucous membranes, catheters, and tubes.
Good. So the means by which pathogen enter the body. So he gave tracts. He did respiratory, mucosal, GI tract. So somewhere where the disease can enter in. So some kind of opening. Good mucous membrane for infection is your eyeballs, right? So don't touch your eyes. Because if you have some germs or some kind of infectious agent on your hands, you rub your eyes, they enter in, okay? So hands off your face, and you can almost prevent being sick, almost, right? No nail biting, don't put your hands in your mouth, don't pick your nose, don't swallow your boogers, things like that, right? All the things we teach our kids. All right, susceptible host. What is it?
Person
Any
infected.
especially somebody receiving healthcare.
Good, I like it. Any person who has been infected. So anybody who's been infected, which we should treat as everyone in the facility, right? Because we have that standard precaution that everybody's infected. So really that's how we should view everyone as the rat tech. Everyone has the same disease. Okay, then we have the next section here. Let's see. Asepsis. What do you guys have for equipment disinfection?
Asepsis or equipment disinfection?
Asepsis. Let's start out with asepsis. What is it?
It reduces the likelihood of transferring pathogenic microorganisms or bacteria to a vulnerable individual. So it's, you use equipment disinfection, sterile technique.
Medical and surgical.
Medical and surgical. Okay, so let's break it down. What is equipment disinfection? Or what do you guys have written? Go ahead.
Destruction of pathogens on inanimate objects, but it does not affect bacteria spores.
Good. So it doesn't affect the spores, but we are killing or removing some of them, right? Equipment disinfection. So how about equipment sterilization? What's the difference here?
Treating, heat, gas, and chemicals.
Good. The spores using heat, gas, or chemicals. Good. This is not in order here.
No, it's not. Yeah.
So do we need to know all types of equipment sterilization, like autoclave and whatnot?
Yes, you do need to break down those different ones. I would focus specifically on, I'm sorry, I'm trying to find my way here. This is not in order, so just so you know when you have your Kettering book.
Using heat, gas, and water.
Hold on just a second. Let me find my place here. Okay, it's not in order, but it is here. All right, let's go back to medical asepsis. Something that I would write down is the use of bleach under medical asepsis, or I'm sorry, equipment disinfection. I would write down the use of bleach and specifically the ratio, because this isn't a textbook that you guys use. 1 to 10 ratio. 1 to 10 ratio. That's 1 part bleach, 10 parts water. So that's for your equipment disinfection. Is your old book in order, Nina? No?
The cycle infection was out of order, but then the rest seemed to be okay.
I will say that the radiography prep has it exactly in order.
Okay.
Following.
Interesting, interesting. All right, so what else do we want to talk about here? Okay, let's talk about medical aseptic technique. Medical aseptic technique. We're on section 2, letter C, medical aseptic technique.
Healthcare practitioners must practice this at all times.
Good. Anybody have anything else for that section? What is it? Medical aseptic technique.
So I put up that the microbes are not eliminated, but instead their environment is altered so they can't grow or reproduce.
Good. So I like to think about it as like a clean concept. Medical aseptic technique. It's a clean concept. You're cleaning, you're wiping down the surface, but you're not eliminating completely, like Nicole said. What about sterile technique?
Elimination of all.
Elimination of all. This is where we can talk about the use of different types of sterilization. So we have boiling. You guys might want to write this down if you don't have it. Methods of sterilization. So you can use boiling, which is obviously going to be a wet sterilization. You boil something for 12 minutes, right? Boil it for 12 minutes. We have a dry heat, which I don't think you need to know the temperature, but I would know that it's 1 to 6 hours. So has anybody in an OR ever seen these drying racks where you open up this metal kind of cabinet thing and all of the equipment, all of the devices that the doctor's gonna use are in there, but when you open the door, it feels like an oven. It's really hot. This is dry heat sterilization. There are some facilities that have it. You might not have seen it because we're not medical surge techs, right? So we really shouldn't be in there. But if you ever pass by one of those, it's like a metal cabinet, almost like a blanket warmer. You open the door up and it has all the equipment laid out. It's dry heat, dry heat. So that's what it's doing, it's sterilizing it. So they'll leave it in there for 1 to 6 hours. Gas sterilization is very uncommon. I wouldn't write anything down for that, but I would definitely know autoclaving. So autoclaving. This is a steam sterilization method. This is the most common method for sterilization. Steam sterilization, autoclaving. Autoclaving, yeah. AUTO, and then CLAVING, steam sterilization. That's gonna be your number one, most common, most of your ORs are gonna be using that. Chemical sterilization, it says it can be used on items that cannot withstand heat. So anything that could be burned, like plastic, or anything that could melt. Silicone is only good to conduct heat up to a certain point. So they might choose to use chemical sterilization. And the last two in here I wouldn't focus on at all, because those are very uncommon. Do we feel good about sterilization?
Is UV, the UV thing, part of the category?
UV sterilization?
I know they do that like pulsing thing.
Like the UV lights?
Oh, like for COVID.
I know. That's so new. I wouldn't think about it. I mean, really, that was developed like 2020, so I don't think we are gonna have anything like that on our registry. Probably the next time though. We'll have this whole list for COVID.
Yeah, COVID. I'm so glad we don't have to.
Yeah. It'll be like what's fact and what's not, and then they'll have like a vaccinated section and an unvaccinated section, mask section, unvaccinated. It's just this whole big thing, right? Whole big thing. All right, let's go down to, yes.
Did you give it a time frame for the autoclaving?
There's not a time frame because it depends on the type of equipment and how dirty it is. Sometimes they do a wet sterilization first, or a chemical disinfection or sterilization, and then they put it in the autoclave. So it depends on what you used before. Know that it's the most common, and know that it's steam sterilization.
Okay.
Yep.
Yeah.
Yep. All right, so our next section here, where are we? CDC, speaking of COVID, right? CDC standard precautions.
Real quick, so we don't have to know like specific sterile techniques or like how to open sterile packs, like the order.
Yes, but I think they're later on in here, aren't they? Sterile tray?
Yeah, I did say,
I think it's
assisting with sterile tray and pouring solutions for sterile
That's
procedures.
what I have.
under sterile procedures. You guys have that, or is that another section on our,
I have it
list?
under sterile technique.
You have it under sterile technique. Okay, let's go back there and let's talk about the tray now then, because we do need to know that. Assisting with sterile trays. So what do we want to know?
First flap is opened away.
Why? Why is the first flap of the tray opened away from you?
Because you're not sterile.
Because you're not sterile, you should be, right?
And you could lean on it.
You could lean on it, exactly. So when you see a sterile tray, your number one indicator here when you open it is you open the first flap away from you. Because if you open this flap towards you, you would be reaching over it to open the other one. Okay, so first flap is gonna be away from you. What else is important to know about a sterile tray?
Don't touch it unless you're sterile.
Don't touch it unless you're sterile. Good, I like it. Anything else? I know you guys, well,
Keep your
hopefully we went over how to properly open things.
gloves, or you have to keep your hands above your waist.
Hands above your waist, good.
I also know the drape doesn't really go all the way over, so don't let anything go below it. Also, if you're pouring stuff,
Pouring stuff how?
contrast, you don't, like, let's say the bowl's like this,
Mm-hmm.
you don't wanna pour it like in, you wanna pour it over
Good,
and kind of away.
good. Away and over. The technique is actually beside or behind it, is how they'll note it in a book, but you don't wanna straight up pour contrast on a tray like this, right? Cause it'll spill out of the bowl. How about needles on a sterile tray?
Never recap them.
Never recap dirty needles is gonna be in there, good. What else do we need to know about sterile trays? I'm just trying to think.
Labeling everything as you go.
Good.
And, flushing stuff out.
Flushing stuff out as far as.
Air bubbles.
Good, like air bubbles. We wanna make sure, I think that's under pharmacology though.
Check expirations on like contrast.
Good. I guess we're gonna talk about all these when we get to the contrast section.
Yeah, a lot of it repeats itself.
Yeah, it does.
Okay, so let's skip over that for sterile tray and let's talk about, is there a section in here about how to pass?
Like front to front or back to back.
Like
Mhm.
sterile corridor too, that one.
It's probably gonna be
You
under,
never go between the
Mine's
surgeon
under
and
hand
like,
hygiene.
In the
under
table.
sterile tray. Sterile.
good, let's go ahead and talk about it. It's probably discussed in detail, or you might have wrote it under CDC standard precaution, use of PPE. But let's talk about how we pass in a surgical environment. So you guys know they love to use like the more right answer or the more correct answer. So technically, if you're sterile and I'm sterile, if we were to pass, stand up for me if you don't mind. If you feel okay. Come right here. If we were to pass and we're both sterile from the waist up, assumed we've already scrubbed, we've already dried off, we're gloved up, we have gowns, we have headgear on, we have shoe booties, we're completely sterile. Her and I are basically the same height, so we could pass front to front. So put your hand like this, right? We're in a sterile environment. So we could pass face to face right here, right? Front to front. We would not want to pass like this, where I'm back and she's front. And same thing if you switch over. I wouldn't want to pass her like this because our backs are considered what? Dirty. Okay. The preferred method, number one method for passing in a surgical suite is back to back. So flip around. So we would pass just like this. So if I had to walk beside her, back to back is your safest bet. However, if you get a question, thank you. If you get a question on a registry or a mock that does not give you an option for back to back, you can pass front to front. You just risk if one person is extremely tall and one person is short, like if somebody's really tall, you guys know I'm short, I could be potentially close to their waist, right? Waist down is unsterile. So if back to back is not an answer, you can pass front to front. Back to back is your number one preferred method for passing in a surgical environment.
So isn't, like if you're in a sterile gown, I know you pull the thing and wrap around, so wouldn't you technically be sterile all the way around?
It only
It's not
ties
as
around.
around.
No.
Your back's still open.
Right. Your back is always gonna be open a little bit.
But I thought it ties in the back and then there's another thing that goes around that closes the back.
It just ties.
It just wraps it, but it doesn't truly close it. You're still open. And waist down is important when you talk about trays. So if you have a drape right here or some kind of bed right here, if this is my patient, underneath here is not sterile,
Yeah.
right? So we're assuming that every time I touch it, my waist down is dirty.
Gotcha.
Good. Good questions. Good questions. All right, anything else we want to talk about in sterile technique before we move on? I think we got everything. Okay, let's talk about CDC standard precautions. So we're in section 3 now, CDC standard precaution. What about hand hygiene do we want to know?
Before and after every patient, and 20 seconds should be your hand washing time.
Good. 20 seconds, a full 20 seconds when you're washing your hands. And just so you know for the future, it's not the temperature, it's not the soap, it's the friction. So when you're rubbing your hands together, that's what's killing the germs. So the water will wash it away and the soap will help in the antibacterial factors, but you can't kill everything, right? Unless you have one of those nice sterile scrubs. Ooh, I love those. They're just so satisfying. Those iodine based, I would just want those in my house every time my kid comes in with dirt. So nice.
Paper towels.
20 seconds and washing before and after patients. That's gonna be your registry question if you get one. 20 seconds and washing before and after every patient. Okay? Using paper towels,
So
good.
like turn on and off the water.
Good, using paper towels to turn off and turn on the water, especially turn off the water because you wanna be able to keep your hands clean.
Sink is considered contaminated.
Good, the sink is considered contaminated, gross, all of our germs are going in there. Anything else we want to discuss with hand washing?
Sterile procedures, you wanna wash your hands for 5 minutes.
Good. Sterile procedures, you want to scrub your hands for 5 minutes. Remember, it's that scientific evidence that scrubbing is what's killing things. So that's why hand sanitizer is not super effective, right? Because we just go seek. Done. But when you wash your hands, you're constantly scrubbing. Did you guys get the opportunity to see how you scrub your hands in class?
No.
You did? No? Okay. They have a glow light normally? Do you guys have a glow light? No? Okay.
You said 5 minutes?
Yes, 5 minutes for sterile.
Yeah, you wanna keep your hands lower than your elbows.
Good. Hands lower than your elbows is important. Why?
Cause it goes down.
Good. So if your elbows are lower than your hands when you're washing them, potentially you could be contaminating them if anything's dripping down. How about scrubbing? What's the method of scrubbing? scrub down. So you start at the elbow, if you surgical scrub, and then you scrub down to your hands.
Scrub down, rinse down, dry down.
Good, yeah.
I forgot to say too, for the sterile technique, whenever you're making the patient sterile or like the area that you're wiping down
Mm-hmm.
with the chlorhexidine,
Yes.
you're supposed to let it dry, you're supposed to let it sit for 3 minutes.
Good, there is a dry time for everything. I hope you guys know that.
Yeah.
There's a dry time for almost everything. So those caddy wipes, those purple top wipes at the facilities, if you turn them around, there's a wet and a dry time. Everybody know that? Right, okay. So if you don't let it dry in between a patient and you use a paper towel to dry it off, it's not killing everything. So don't do that. Okay? It's nasty. It's not killing stuff. All right, anything else with hand hygiene? How about the use of PPE? We should all be professionals in this day and age, right? You guys are always using this. What do you have for the use of PPE?
Clean uniform, one daily, no artificial nails. Only jewelry you should have is a wristband or a wristwatch or simple wedding band.
Good.
Just for like daily stuff.
Okay, good.
That's not really protective here, but.
I'm gonna try to buy the glow light for you guys so you can do that before you graduate.
Gloves, gown, mask.
Good, gloves, gown, mask. The glow light is important because everybody washes their hands differently. And what you do basically is you pour this powder on your hands first to contaminate you. And then you wash your hands normally like you would. And then you come back and put it under a black light and you see the areas that you miss. So it's really important that they, especially right now with hand hygiene like being escalated completely. All right, gowns, gloves, and masks. What do we want to talk about with these?
So must be worn anytime you think you're gonna come in contact with, a patient's bodily fluid or if they're on isolation precaution.
Good.
It's provided by the hospital for no extra cost to the healthcare worker.
Good.
And it provides a barrier, between the patient and the, healthcare provider.
Okay, good. Yeah, right now, everything's not really included, right? It's like bring your own mask to work day. But remember, that's not registry, so. Anything else we want to know, as far as gloves, gowns, or masks? You guys know that certain types of infection require different masks, so that's why we use the N95. Right now, we have surgical masks just for everyday use. Now we wear a mask all the time, right? So, anything else with these three sections?
It kind of goes into detail about that in the transmission-based precautions.
Okay, good.
Like which rooms you wear what.
Good, good, good. Anything else with use of PPE? We always treat everybody as if they're infected, so I would say wear gloves with every patient. You will see people not using gloves. That's really nasty. Don't do that. Protect yourself, protect your family. Okay, how about safe handling of contaminated equipment or surfaces?
Like toxic and hazardous waste or?
Well, like, for example, if you're cleaning something and you have blood on your gloves, change your gloves
Good.
to clean it down.
Exactly. So
Don't
you're
clean with
supposed to
dirty
change your gloves after you perform the exam before you clean. Okay, you guys know that? You're supposed to change your gloves after you do the exam before you clean the room. That's the standard.
And then basically just make sure you're using the correct disinfectants for like type of dirtiness.
Good. I would also say in this section, clean tech, dirty tech. If you're working with two people and you're doing a portable exam, one tech can stay clean, only working with the equipment. One person can stay dirty, always touching the patient, positioning the image receptor. That's a really good way to prevent infection. Clean tech, dirty tech. Anything else for this section? All right, let's go for disposal. Disposal of contaminated material. First, it wants you to talk about linen. So how do we dispose of contaminated linen?
Contaminated versus soil.
Okay, good. Contaminated versus soiled. What's the difference?
Contaminated is just like was used in an exam, like on a table, and soiled is like has matter on
Good. Has matter or bodily fluid. Good. Contaminated versus soiled. So everything is contaminated once a patient touches it. If it's soiled, you could see or feel something on it, right? Some kind of bodily fluid. So urine, throw up, fecal matter, blood, things like that. So do we separate these two?
Yes.
Yes. The bags, do they give you a specific color?
Blue. Or red, too.
When it comes to linens, they only put all linens in
Yeah.
blue bags, they don't separate them, but
We don't
when it
really
comes to,
separate
like,
them.
no
I've
waste,
never separated them.
they do, like trash versus like
Yeah.
bio has waste.
Okay. What's important about the bag?
Waterproof.
Waterproof, good.
And that you tie it properly, there's a certain way.
And permeable.
for like
Good. So they don't give you a specific color, so I'm not gonna give you a specific color, but know that if it's soiled versus contaminated, it should be separated, okay? You should separate them into two different bags. I don't know what it's gonna look like site specific, and there used to be a color back in the day that they used, but I'm guessing they dropped the color since everybody's using whatever color bag. It has to be waterproof and permeable, and you have to tie it properly. Okay, feel good about those? Moving on to needles.
Always
Moving
be
on to
good, so it's a sharp container.
Should always be disposed of in the sharps container, good.
Needle in first.
Needle in first, never recap dirty needles, right? Better to toss the needle than to get stuck. Anything else we wanna know about disposing of needles? Container needs to be puncture proof. In addition to that, a sharps container will have a level or a limit when it's full. Technically, if it's full, you should not put anything else in it because you could get stuck. So that's why it has a fill line. Because if you're disposing of a needle and it's past the fill line, you could potentially get a needle stick. So it needs to be disposed of properly. We don't put these in, we don't just dump out the sharps container in a regular trash can. Somebody comes in and disposes of them. Remember, the cost of a sharps container is higher than regular garbage, so we only put sharps in it. So we're not gonna put gloves in them, we're not gonna put needle cannulas, anything like that that's not actually sharp and can poke you. So the disposal is very high on that. I think we're good on that. Anybody have anything else for sharps or needle?
Don't grab the sharp side.
Don't grab the sharp side. I would also say never put a contaminated needle down on a surface. So directly from the patient into the sharps container.
Sharps trash.
I just went over all of this, then I'm telling you to throw a needle in the trash. Don't do that. Don't do that. So directly from the patient, or if you're working with sterile tray, they'll have a sponge or some kind of hard porous surface that you can take the needle out of and put it directly in there. Sterile trays are important. Never take a needle and set it down on a sterile tray because if you reach over it and pull your hand back, you can get stuck. Okay, so there's always a designated area for a needle on a sterile tray, or it goes directly into the sharps container. Never leaving it on a surface to stick someone. Never trying to attempt to recap it at all. All right, next section, patient supplies. Disposal of contaminated material, patient supplies. What do you guys have for this section? I can really only think of one thing specifically.
Like biomedical waste, there's in the.
Go ahead. What specifically would a patient use that you might have to dispose of? Urinal, good, urinal, or bedpan, right? Urinal or bedpan. So how do we dispose of this?
Dump contents in the toilet unless it's being sent off for specimen.
Good. Dump the contents in a toilet unless it's being used for a specimen. Always use gloves, right? And I think they give you a technique in the patient care book of how to pour a urinal in to prevent splashing. You obviously don't want to stand above the toilet and go like this, right? So make sure you get down on the level of the toilet when you're disposing of a urinal or a bedpan.
And you rinse it out before you send it off for cleaning.
Yes, rinse it off before it is sent out for sterilization. So if the bedpans are reused, not all of them are. Usually they're disposable nowadays, which is kind of bad, right, for the environment. We're not recycling anything. But most of those plastic ones are just disposable. So assigned one patient per stay in the hospital, and then when that patient leaves, they're put in the trash. If they do get sterilized at the facility, you need to rinse it out before you send it off to be sterilized. Yeah.
Also, if you're using like the cut down trays or like the surgical trays with like all the scissors and stuff, they have like a special spray that you're supposed to spray on it too before sending it
to sterilization.
I don't know what the spray's called, but
It's just a disinfectant.
Okay.
It's just like a chemical disinfectant. So you wanna clean the stuff before it's autoclaved, is basically what you're doing. Think of it like you're rinsing the stuff before you put it in the dishwasher. It's kind of that method. All right, anything else for patient supplies?
So the urinals, you dump in the toilet, you're wearing gloves, do you rinse it out?
Yes.
Are you rinsing it out of the sink?
Yes.
And so, and then you can put it in the regular trash, or does it have to go biohazard?
Good question. If you're disposing of it, once you rinse it, you can put it in regular trash. Cause it's considered not soiled, right? Cause it's cleaned. Right?
that's not clean.
Yes.
I have a question with, stuff for chemo, is that yellow? Yeah, yellow.
Yes.
And that gets incinerated?
Yeah, so chemotherapy disposal of those chemicals or biohazards, you never wanna pour any kind of chemotherapy or any kind of pharmacological agent down the toilet, including barium. So things like that, so there's proper disposal of those. Normally chemo is noted with a yellow bin, and I think that's standard for everyone. So chemo is gonna be yellow disposal, yellow bag disposal, or yellow container disposal, depending on what kind of substance it is. If you're disposing barium, how do you get rid of barium? What do you do? Black bin, good. Black bin, good. So we never pour it down the sink, right? It's a heavy metal. So if you pour it down the sink and it goes into the irrigation system, you're gonna be eating green beans that have metal in them one day, right? This is why we don't do this, right? This is why we don't flush fentanyl down the system, so we don't have corn that's glowing one day, right? So protect the environment, dispose of bio waste properly.
When
Good.
you're lock and sealing it is when you're taking them like out of the department.
Yes. Mm-hmm. Questions on that? Feeling good?
So like thick and thin, go in black bin?
Yes. Yes, they do.
Like
They just throw them away.
Yeah, they should, yeah, it's so like speech, there's also like the cups and it has some on there. That could be like that.
I've always just thrown it away.
And positive
It happens. It happens everywhere. Yeah,
It's
but
like
you're not supposed to
those
do that.
big bottles.
That's why we're here to make a difference.
That's right. Just wait until Jayco comes to the hospital. And watch what they tell you to do. That's how you know the right and the wrong way to do things.
Yeah.
People will say, oh yeah, everyone remember to throw your barium in black bin this week. Like, why haven't we been doing this?
Yeah.
Everybody feeling good? We're still good? Ready to continue? Anybody need a break?
No.
Feeling okay? All right, let's keep going. We're gonna stop halfway, so we're almost halfway. Let's push through at least additional precautions. Okay, so blood and bodily fluids. Blood and bodily fluids. Good. Biohazard bags. Biohazard bags. We already talked about soiled linen, so that's gonna be separated from the regular contaminated linen. Blood and bodily fluids, biohazard bags every time. Never wanna put blood in a regular trash bag, alright? Questions? Feeling good on that? Okay. Next section, safe injection practices. I feel like this is new from prior years, cause I don't really remember talking about this.
Like how to properly clean the site.
Safe injection practices, why would this be here and not in pharmacology? Alright. Cause it's a CDC standard precaution, so safe injection prop. What do you guys have for this?
I wrote down like when you're taking needle out, like you wanna apply pressure
Okay.
to the area, but I don't know if that's really.
Anybody have anything else?
Would that include like?
Are you on
using
safe
the alcohol, like you go out in a circle?
Cleaning properly
Yeah, go out
before
in a
injecting a
circle.
person? I would say yes. The proper way to clean
Every read this stuff, there's like a little,
on the CDC.
box.
Is it from CDC?
Yeah.
Yes. Please read it to us, yes.
So it says wash hands thoroughly, put on disposable gloves, check the patient's two identifiers, explain the procedure to the patient. Prepare the site by cleaning with alcohol in a circular motion starting from the center out.
Good.
Inspect the needle for imperfections and discard if any. With your free hand, you're gonna pinch the skin together and insert the needle quickly at the appropriate angle. Release the skin and pull back a plunger to ensure that you're not in a blood vessel, and then inject the drug slowly and quickly. Withdraw the needle at the same angle used for insertion. And then you're gonna massage the site with an alcohol swab with gentle pressure. Dispose of the needle and syringe properly, and then chart all relevant information.
Good. Okay. I'm not sure why they decided to put that there because it's CDC, I guess. I think it used to be under pharmacology.
Maybe
so.
it's just
I
to
think
help prevent.
I think I did read that, and then I remember that I need to write it down, cause you had that sheet when we did the
Venipuncture.
So
Yeah.
is that all we really, as far as procedure for safe injection, it's just venipuncture for
Yes.
us for radiography? Then?
Yeah.
Like if it
Well,
was
venipuncture
CT
or it could be a contrast agent.
IV.
So like IV.
something. Okay, so,
But it's the same method. Just make sure you're identifying your patient, make sure you're cleaning the site properly, make sure you're injecting at a correct angle depending on what kind of drug you're administering or to what thickness or depth in the body you're delivering the medication to.
I wrote that down in pharmacology under administration.
So like hypodermic needle, IV catheter.
Yes.
Winged infusion set or.
Yeah, I think we'll
venipuncture,
talk
that's pretty much it.
I think we'll talk about that under pharmacology too, under supplies for administration. Okay, everybody feel okay about safe injection practices? I think we know it. All right, thank you, Nicole. Transmission-based precautions. So we have contact, droplet, and airborne. So tell me about these. What's contact? What are you required to have? Yeah.
For contact, the protection, it says the patient is in a private room, wears a mask if required by your facility. The radiographer should gloves and gown, masks for MRSA if required by facility.
Good.
And then for examples of contact, I put mumps, MDROs, which are antibiotic resistant organisms such as MRSA and VRE.
Right.
Or like C.
Yeah.
Or some wounds.
Nice string stuff. So gloves and gown, this person has to have their own room. So I know that we don't really see this a lot at our facilities, but I can think of like UF and St. Vincent's, they have joint rooms sometimes. And I mean, things are kind of progressing with our kind of shortage of hospital rooms anyways due to COVID. So you might see people sharing rooms. If it's a contact patient, they're not allowed to share a room. Okay, so they have to have their own room, and gloves and gown is needed for us. Typically, we wear a mask too. It depends on the type of infection though. And you guys know from the signs on the door, we'll usually tell you what to wear. However, I highly recommend checking the chart before you go in the room when you are attacked, because they don't put those signs up in the ER immediately, right? That's how you're gonna end up getting things like TB or some kind of airborne or droplet that you don't know that the patient has. So they're really slow to put those signs on.
We went upstairs yesterday, me and Ashley to go do a portable, and this floor, it like clearly had a nurse that wasn't washing their hands after CEDIS, because it was like every other room up there was
Ew.
CEDIS.
So gross, guys.
Yeah, serious.
So gross.
It was like.
Hey, what kind of infection is that?
Disgusting.
Bacterial. I don't want.
Nosocomial. Nosocomial infections or hospital acquired. I think it's in here though. Right? Hospital acquired. Gross.
It
Ew.
smells like bleach up there.
She got fired.
Bleach everything.
Nick and I had been up there before and it smelled.
I mean, that CEDIS smells
And
terrible.
so, and the next time we went up, they clearly.
Every day.
Alright, you guys are making me
Oh.
farm. Okay, droplets.
You don't miss it?
No. I'm a teacher now.
Gown, gloves, surgical mask. The patient should wear one too.
Glove gowns, surgical mask for droplet.
And it says depending on, like, except for influenza, when an N95 particulate respirator mask should be worn.
Right, so
So
there's
depending
certain
on-
cases where we should wear a specific mask, right? So a specific mask for droplet. What we're doing today, right? We wear N95s for COVID.
And technically you have to be fitted for your N95. for
Yes, you
certain-
should be fitted. You should be fitted based on the manufacturer's requirements.
Droplet and airborne, are they both the N95 masks? Okay.
Yes.
For all droplets?
Not all droplets, for specific ones.
You need to know this specific.
No,
Okay, just know that you
you
might.
could wear a specific or particulate mask. Yep, you don't have to know distinguishable diseases. All right, so let's talk about airborne. Airborne.
Spread by droplet, patient talks, cough, sneeze.
Good. We know it's suspended in the air. We talked about that already.
So these patients should be in a negative pressure room, right?
Good. Very important. These patients should be in a negative pressure room. Because anytime you go in the room and you're exposed to the air, you are potentially being exposed. So negative pressure room, something that sucks the air out of it into a different pathway that the normal air is cycled through, right? So we're not gonna share this with the rest of the hospital. Anything else we wanna know with airborne?
They wanna limit patient transport when it's airborne precaution.
Good, so if you had a registry question that said, what would be most important when dealing with an airborne patient? Them traveling down to the radiology department, them obtaining an IV for use of chemotherapy, I don't know, I'm trying to think of other factors. Them wearing gloves and gown, so specifically think about them being transported through the hospital. That's a good point to bring up. If it's an airborne precaution, some droplet now too, you guys know with some of the COVID kind of stuff. They're still kind of not sure for what it is. They're saying it's airborne sometimes or classified as droplet. So that's why we don't see a lot of these patients traveling, or we shouldn't at least, right?
Do you know why, like in the OR, like some surgeries go, like I've seen like COVID positive surgeries, and then some like get canceled if they're.
Depends on like the severity of the need. So if the patient needs it to live,
Right.
it's
Well,
usually
I
a
saw
go.
an ortho case that was COVID positive, and I was like, I don't really feel like
That's not really a necessary thing, right?
Okay.
We could wait.
I was told the other day, I had a long discussion with a nurse about how you can show positive 90 days after you
Okay.
initially test. So like they will have patients, will be full PPE, and then the nurse will be like, you know, it was like 2 months ago, but.
Right.
So they still have
Okay.
it on their chart sometimes.
So if they're
But
testing
always be
positive, but maybe
safe.
they don't have active symptoms?
So like they could have tested them yesterday, but their initial test was.
Right.
Better safe than sorry.
All that good stuff. In like 10 years, there'll be a lot of research out and they'll tell us that we shouldn't have done this and we should have done this, and this is why it's practicing medicine, right? Something that we've never dealt with before. Okay, everybody good on contact, droplet, and airborne? Okay, let's move on to additional precautions. So neutropenic, what is it?
Reverse isolation.
Good.
It's used to keep the susceptible patient whose immune system is compromised from becoming infected. For example, people with burns, because
Good.
they lost their skin protection. And then it also said people who are immunocompromised, for example, transplant recipients, leukemia, and chemotherapy patients.
Good. I think about HIV patients, AIDS patients, lupus patients, cancer patients, chemotherapy and burns like she talked about. So neutropenic, this kind of precaution is for the patient's protection. So if it says reverse isolation, you are not going to get anything, but you wanna make sure that you wash your hands thoroughly, gown, gloves, mask to protect the patient.
And you wanna play clean tech, dirty tech for those patients.
Good. Clean tech, dirty tech with these patients. Who should be touching the patient?
One
Clean
person.
tech. Clean tech, good. So the clean tech should be touching the patient in a neutropenic situation. Because remember, it's not the patient that's dirty, it's us. Okay? Next. We also have, I have strict in here in this category book. Did anybody find strict precautions? Was that in a textbook?
I just looked, I didn't find it.
Hold on just a second, let me read it.
Hurts.
Yeah, we don't need to know that. No, I would scratch out strict if you have it, you don't need that. Okay, and then our next section is healthcare acquired infections, HAIs, or nosocomial infections. What are they? Nicole's story, right?
Infections acquired by the patient in the hospital and not the original reason why they were there.
Right, good. So not the original reason why they were there. So they come in and they're having right leg pain and they leave with MRSA, right? So something that they picked up there. Hand washing is your number one technique to prevent these infections, right? So hand washing is going to greatly help you. And what else do we need to know about HIAs, nosocomials? The number one in the hospital is a UTI. I would know that. Number one in the hospital is a UTI, and it's used when you do not clean someone properly and use sterilized technique for the insertion of a catheter. So that's your number one nosocomial infection, a UTI. Others might include C. diff, MRSA, or SARS.
Do we know those ones too?
All right, feel good about those?
What's SARS?
SARS is a type of MRSA specifically. Yeah.
So you said UTI is the number one nosocomial infection.
I would know UTI for sure.
And you said it's from properly not cleaning up, and then you said something about,
It's for if you get a UTI, it's from a patient that needs a catheterization, but you're not using a sterile technique or you didn't clean properly. Yeah, it happens all the time to these poor patients. So if you ever have to get a cath in the hospital, like really pay attention to what they're doing, because tons of people leave with UTIs because of this.
Is this the one that, thank you, it has to develop 48 hours after admission?
There might be a time limit on it. Did anybody find a time limit on this one? Yes?
Yeah, infection acquired during hospital care, which are not present at the time of admission. Infection occurs more than 48 hours after admission and are considered nosocomial. And pneumonia is the second most common one, after UTIs.
Good, I like it. Good. Everybody feel okay about those?
you say 48 hours?
Yes, she said 48 hours. So it has to be something that you didn't come in with, and it has to be acquired there. That's probably why they give you the 48-hour limit, just so you know that you're not coming in with it and it's developing kind of in a latent period.
That's for the,
Nosocomial.
okay, not for the UTI.
Right.
Specifically, like it's for all of them.
Yes, for all of them. UTI could be a nosocomial infection.
Gotcha.
Okay, this last section down here, handling and disposal of toxic or hazardous material. So we have types of materials, chemicals, and chemotherapy. Chemicals and chemotherapy. Let's talk about chemicals first. Handling and proper disposal. What do you guys have? Should be kind of simple.
Just making sure you're wearing the appropriate gloves.
Right.
Handling chemicals and then, disposing of them properly.
Right, making sure that you're wearing gloves, making sure that you're not swallowing them, right? We're not gonna walk up to some disinfectant and say, what does this taste like? Not a good idea, right? Using your noodle. What is this used for? Not swallowing, not inhaling it, not putting it in your eye or your mouth, right?
No, I won't see that.
Make sure you read the label of these materials and chemicals so you know how to use it, and maybe the wet or the dry time if it includes that. Use it only as directed.
I have for like, if it touches your skin, you should wash like for 5 minutes, and if it gets in your eyes, you should rinse for 15.
Nice. Okay, let's write that down. I think that's important. Under chemicals, if it gets on your skin, we're gonna rinse for 5 minutes. If it gets in your eyes, we're gonna rinse for 15 minutes. So that's why we have those eye wash stations. Okay, now it does happen. I did have a student one time that was pulling out a cavity wipe, and it was kind of like the bottom of the pack, and when she pulled it out, a string of the chemical went in her eye. So I have had somebody that cut eye contact accidentally. Say 15 minutes. What about chemotherapy? Even though we don't really deal with this that much,
Do not touch it.
don't touch it.
It comes in depending on how, like, I guess, the strength of it, it comes inside like a lead line thing, and it needs to go inside a bag, inside a bucket, when you're disposing of it, and you wanna wear sterile gloves when you're touching it.
Good. Anything else for chemotherapy? Disposing of it properly, making sure that you're using gloves.
And you have to, when you like put it in the bag, you have to open the bag like, kind of inside out at the top.
So you keep it sterile.
Yeah, and so you don't like,
Get anything on you? Yeah. So she's saying there's a proper way to open it. You don't just wanna kind of open it because you might get it on yourself or you might contaminate it. So she's saying when you open it, kind of fold it out. Good. I like it.
and it can only touch the patient because it's going in them.
Okay, this is a good one. Containers should be a different color, which we talked about that, yellow color, right? Then other hazardous waste and must be labeled appropriately cytotoxic waste. Might wanna write that word down if you don't know it. Cytotoxic waste is what they consider to be chemotherapy agent. Cyto,
label that?
yes. Yep, CYTOTOXIC. It says it must be labeled cytotoxic waste. All right, and then the very last thing before we take our break is gonna be the MSDS. This is typically not in the book either. So what do you have written down for this?
Safety data sheet.
The safety data sheet, the MSDS. Protocol's good. So basically there has to be somewhere in your department that has a protocol. If somebody touches something that's hazardous, it has everything listed out. That could be hazardous, or it could be contaminated, or could hurt you on the job. It's required by OSHA. Anybody have anything else for MSDS?
I just wrote, provides direction for handling precautions, safety use of the product, cleanup and disposal of biohazardous materials.
Good, and it has to be located somewhere where you can find it. So if you ever have OSHA or JACO come into your facility, they're gonna ask you, where is the MSDS? It's not like you're consulting with it daily, but you do have to know where it is. Same thing for crash cart, right? It's important that you know where crash cart is in the department, it's important that you know where the MSDS is. Because if something does spill or get on you or touch you, you have to be able to refer to the manual to know how to proceed. Alright, so do you need to rinse for 15 minutes? Do you need to call poison control? Do you need to go to the ER? So it would have all of those specific variations written down. Alright, let's take a break before we go into pharmacology. So I highly recommend closing your book for a few minutes and getting out of the mode so you can kind of detox a little bit. Let's come back at 10:35, that's 15 minutes, and then we'll finish our last section for the day.
Just have to take pictures of that.
Yeah, you can. Separate one. Okay. I did wanna let you guys know if you're at Memorial, I did just get the email for your, 3-4 unique logins. So the reason why I needed that information for the COVID vaccine tracker or declination. So I'll be emailing you as soon as we get out of class. They're requiring that you be in compliance by tomorrow at midnight, okay? So make sure you get on the website, get into the ID, and put your information on there if you're at Memorial, okay? Are we good? Just for Memorial. Just for Memorial. All right, good. Let's finish up here. All right, pharmacology, patient history. Pharmacology, patient history.
Looking at the documents of the medications, history, pre-medications, contradictions with like scheduling, like you don't wanna go to like a CT, then.
Good. What is the order of kind of operation when we talk about GI studies? Can you have an esophagram before you have a BE? Yes or no?
No.
Can you have an esophagram before you have a BE? Yes or no?
Well, I thought it was saying you need to do like the lower stuff first, because if you go up first, then it goes all the way through and there's already contrast there, so no.
Correct. No. You cannot have an esophagram before you have a BE because you have to be NPO for a BE, right? So you would have to do the BE first if you needed both of those studies done in one day. Got it? Kind of order of operation. Can you have an esophagram before you have an upper GI?
I mean, they typically do order that, yes, because isn't it a follow through?
No, it's usually
No.
the upper GI, small bowel.
No. No. How about,
Is this just like, hold up, so is this, you're blowing my mind right now. Okay, so is this in general, like, if a patient needs an esophagus?
if they needed both
Oh, they need it both?
in one day,
Okay, I got you.
like order of operation, scheduling,
Okay, that's
scheduling the
it.
exam.
Okay.
Sorry, I guess I should have been more clear. What about if a person has a chest x-ray ordered and a small bowel follow through? Which one do you need to do first? Okay, good. So any kind of static standstill film needs to be completed first before we introduce contrast agents, right? Because it could show up on the film. What do you have, Jessie?
I have a list of sequence of examinations, there's like 6 of them.
Tell me the list.
Okay, so, it says first any.
She's telling you the sequence of exams, by the way.
So, any fiber optic or endo studies first, then, anything of the urinary tract, then the biliary system, then CTs before exams involving barium, and then any lower GI, and then you wanna check for residual contrast, from previous examinations before you proceed with that, and then any upper GI.
Good. I like it. I like it.
I have here IVP before BE, so like, iodinated before barium.
Not necessarily. So IVP before BE, because the urinary tract would be obscured by BE contrast.
Okay.
Make sense?
Yeah.
Hypothetically, you're gonna drain everything out of the urinary tract before you do a BE, so that's why they're saying that. You could just urinate and it would clear it very quickly. Whereas barium or contrast in the GI tract, specifically the large bowel, would take a long time to exit or evacuate, right? So that's why they kind of give you those orders. Anything else we want to talk about with patient history? Patient history, medication reconciliation. So current medications, we always want to ask them if we're doing some kind of fluoro procedure, what kind of medicines are they on, what kind of medication are they taking? Pre-medications, what do we have for those pre-medications?
Not like a Benadryl or something, if you have like allergies.
Good. Benadryl, and then I think about like CTs or MRIs. If somebody's claustrophobic, they might have a pre-medication of a Valium, something like that. Yeah.
I had an important one, requirements for collecting the patient's urine and so on.
Okay.
So like, let's say they come down to x-ray and they're like, oh, I have to use the bathroom.
Oh, okay.
Like, don't let them use the bathroom if they're gonna.
If you need a urine sample. Okay, good. Good, I like it. How about contraindications? Contraindications.
That's just medication reaction.
Previous reaction.
Previous reactions, good. So your number one contraindication for iodinated contrast is gonna be a previous reaction. So if somebody says, I have had a reaction to this iodine contrast before, contraindication. That's your game changer, right? If it's documented, this person had a reaction, we're probably not gonna give them iodinated contrast again. What's another contraindication for an iodinated based contrast?
Can you repeat that?
Medication.
What's another contraindication for an iodinated water-soluble contrast?
If they already have barium in them?
Medications are on.
Depends. Think allergies.
Shellfish.
Shellfish allergies. Shellfish allergies, right? And I don't know if you know this, you could always ask the patient if they eat white bread because white bread has iodine in it too. So normally if they do have an iodine contrast, they can't do shellfish or white bread. So that will kind of determine the severity, and you can tell the radiologist that too. Okay? Good on that one. What about contraindications for barium?
If they have a perforated bowel.
Perforated bowel, possible perforation, constipation, obstruction, something that could lead to a perforation. So no barium in the alimentary canal if we are suspecting any kind of bowel perf. Nothing. Why?
It doesn't, your body doesn't absorb it.
Your body can't absorb it because it's not water soluble, right? Your body cannot absorb it. Any other contraindications we want to talk about? Anybody have anything else? Let's see. I feel good about that. Ow, I just got a paper cut. Okay, scheduling and sequencing exams, we talked about that. So just use your brain. If they ask you, can this be performed before this? Think about it. Is there gonna be residual contrast? If it's a static x-ray or a standstill, not dynamic imaging, so hand, foot x-ray, toe, skull, something like that, we always wanna do that first. So we have no contrast or no possible contrast agents obscuring any type of anatomy. I'm thinking that would probably be your basic question here. All right, administration. Let's talk about routes of administration. I taught you these, I believe I taught you these when we did venipuncture, so.
Oral,
Rectal.
Good, let's go through them individually. So oral, where is it? Good, what's the next one? IV, good. Intravenously.
Rectal.
Rectally, good. I'm sorry, I couldn't hear you. Intramuscular, good.
Nasal.
Subcutaneous, good.
Topical.
Intradermal, good.
Topical.
Topical, good. What's the difference between intradermal or topical?
Intradermal is within the skin. Topical
Good.
surface.
Good.
Intradermal would be like your TB test, is that considered?
Intradermal, so I think about like an intradermal patch.
Yeah.
Yeah, so remember, associate intradermal with patch type therapy. So it's timed to release a certain drug at during a certain period of time. Whereas topical, just like you're putting it on, there's no dosage. So it might say, rub a pea-sized amount on your skin versus a patch where you put an intradermal patch on. It's gonna actually time release it, so the dosage would be more accurate. Those would be for like pain patches. Yes, exactly. All right, do we feel good about the routes? How about supplies? What do we have for supplies? We have enema kits and needles. Remember, we're under pharmacology administration. So in this section, I would probably break down what you need for different types of exams. What do you guys have? What did you guys put down?
So which one?
Supplies for administration under pharmacology. Supplies, and it says example, enema kits and needles.
For needles, I listed the parts of the needle.
Okay, for needles, you could list the parts.
Like the gauge,
Good.
identifies the diameter, the larger the gauge, the smaller the bone diameter, the smaller the gauge, the larger the bone diameter.
Good.
And then I just said what the hub was, part of the needle.
Okay. Anybody else have anything else for that, supplies?
Like tubing, like the enema bag, and then tubing, clamp.
Good. For an enema, you might need a tubing system. You might need a clamp to actually clamp it. You're gonna need some kind of IV bag or bag to put the contrast in for sure. These are basic things that you guys are already used to practicing, so you don't have to write everything down for this section if you don't want to. But I would definitely know kind of the different supplies that you might need.
For how many different exams do we need to know, like what type of surprises do they ask specifically, like make a random exam? Like barium enema, each this and this.
For supplies, they might ask you a question. I think needle composition is a good one. They might ask you a part of a needle, or maybe a method for administering venipuncture. Like what part of the needle goes in to the patient. They might ask you a bevel question, something like that. For enema kits, I think they would probably ask you like maybe a general allergy question, like we don't want it to be composed of any latex. We want it to be silicone or plastic only. What part of the device goes into the patient? How about how high the bag needs to be? That's probably important.
18 to 24.
Good, 18 to 24 for a contrast enema, 18 to 24 inches or a contrast enema, I would for sure know that.
Same thing for like an IV bag.
IV bag is the same, yep, good. I'm just thinking they might ask you,
I think too it said something about like, if they have like a urine bag.
where it should be
Foley,
placed.
like
a
below
Foley
the
up
level of the bladder,
there. Okay.
so
goes
to prevent
in.
infection.
Goes in the top, everything goes down.
Good, everything that goes in goes above you, everything that comes out goes below you. Good way to memorize it. I think we're pretty good there, I think that's pretty generic.
What was it? Was it bevel up or bevel down?
Bevel up when
Bevel
inserting
up.
a needle, yep. Bevel up when inserting a needle. Good. And then we have contrast media dose calculation. What do we have for that? Did you guys put the amount of contrast that you would need?
No, I just put based on age and weight.
Based off age and weight is probably pretty generic, that's probably pretty good. Know that if you have an infant or a pediatric patient, you're gonna be giving them less contrast. We don't calculate a dose, it's department specific and radiologist specific. You guys know they might like to use a specific type of iodinated water soluble contrast, or they might want to give initially 1 cup of barium and then switch to a thicker kind. So really it's specific to the physician. I would just know that it could differ based on the size of the patient and the age of the patient.
Also depends on healthy adults or people with renal dysfunction.
Good. Depends on the type of patient you have. Is the patient ill? Do they have some kind of renal insufficiency? Or are they able to process everything? Good. And we're gonna talk about those laboratory values, and that's kind of where we'll talk about that in just a second. Good. All right, contrast media types and properties. The example is iodinated, water soluble, barium, ionic versus non-ionic. Shelley did a great job of getting us up to date there. The only thing I wanted to touch on here just a little bit to distinguish the two that I wrote down when she was presenting. So we have barium contrast, right, which is a positive agent, which she talked about, radiopaque. And then we have iodinated water soluble contrast, right? So 2 different forms, both positive agents, both radiopaque. Under the category of of iodinated, you have ionic and non-ionic. So you guys know that those fall under iodinated contrast agents, right? So separate them. So we have barium over here, we have iodinated contrast here, and within that we have 2 subcategories, ionic and non-ionic. So I want you to write this down if you don't have it. Ionic has 2 charged particles. 2 charged particles. It's kind of a good review. It's called a cation and an anion. So a cation and an anion. It's different than you would think. You would associate cation with cathode thinking it's negative, but it's not. Cation is actually positive, and the anion, A-N-I-O-N, is negative. So cation, C-A-T-I-O-N, is gonna be your positive particle, and then the anion, A-N-I-O-N, is gonna be your negative agent. These two separate in this ionic solution, and basically you can think of them as 2 arms. So I like to think when they enter the body, they're like this, and because they're charged, remember that law of electricity, that law of attraction, if they are charged differently, they wanna separate and come back together. So that's why they're highly reactivity rate. So highly reactive, high reactions, high sensitivity for these 2. It is less expensive than a non-ionic contrast because you have a higher reactivity rate, right? So everybody prefers the non-ionic contrast. The non-ionic contrast, it has 3 particles and they stay together, right? So all of these both contain iodine. So if they ask you a question, which one does not contain iodine, non-ionic, ionic, or barium? The answer is barium, right? So ionic and non-ionic are both iodinated water-soluble contrast. Your ionic is more highly reactive. It is less expensive.
Which one is that one less expensive?
Ionic. Ionic, you have the 2 charged particles that separate. Okay. Less expensive. right? Because they wanna charge you more for that one that is a little bit better for the 3 particles that stay together, and that is non-ionic. Yep,
Which one's
they
more,
all bind together, it is more expensive to purchase that one.
which one's more reactive?
Ionic,
Okay.
because it's the 2 particles that separate, they interact with your cells, and then they come back together. So that's how you could have a reactivity rate in your body that's increasing. That's just one thing that I wanted to touch on, that I feel like some people get confused about. How about what if I ask you, what is the most common contrast agent?
Barium.
Think really hard.
Air.
Air, good, air. So the most common contrast agent used in radiology or radiography is air. Why? Because we take tons of chest x-rays. All right, what are we using? Take a deep breath in. We're using air, right? We tell the patient take a deep breath in, the air fills their lungs up, and that is the most common used. Now, as far as positive agents, yes, barium is our go-to, right? Low reactivity, low sensitivity, low toxicity. Barium is a safe player, as long as there's not a contraindication. Everybody feeling good on those? Does anybody want to go into detail about any of those before we move on? I think Shelley did a good job.
So barium is positive,
Mm-hmm.
it's radiopaque,
Radiopaque, yep.
opaque.
Okay.
And then the iodinated has 2 categories, you have your ionic and your non-ionic.
Right, they're both positive.
Okay, and that's the ones we gotta watch out for the shellfish allergies and stuff
Yes,
like that.
iodinated contrast agents.
And they are, okay, and then air is radiolucent.
Good.
And it's negative.
Good.
Okay, am I missing anything?
Yeah, what about the fizzies? What do we call those? What's the proper name for a fizzy? Well, it should be named like a CO2 crystal or something like that. What's it listed out in your book? CO2 formulated crystal or something like that? I just don't want that to throw you off if you see that on a test question. It's a fancy name for a fizzy, right? You could also use tablets. The tablets are crushed together. They're CO2 particles. You could use soda water or some kind of sparkling mineral water to induce air. Okay, those are all negative contrast agents. Anything that brings air in the body is going to be negative.
So you said that fizzies considered negative.
Yes. Yep. Fizzies introduce air. That's what they do. Yes.
Sorry, for the contrast media dose calculation, what did we all decide we're putting down?
I would just keep it generic and say you can change contrast amounts based on the age, weight, and condition of the patient.
Okay.
Mm-hmm. So if you have a younger patient, you're going to decrease the amount. If you have an older patient and a larger patient, you might want to increase the amount.
So pretty much like the answer will go put for appropriateness of contrast media.
Yeah.
Okay, so just like repetitive, okay.
Yeah.
Thank you.
Yep. All right, how do we feel about contrast? Good.
The tablet was negative also.
Tablets are negative too.
And then what was the
know
other
the
thing
particles
about the fizzies, the CO2?
CO2. Let's see if we can find it in this book.
Yes, no. What about?
What is it called? What is a fizzy called? What's the proper name? Pharmaceuticals. Drug interaction. Barium sulfate. It doesn't say anything in this book. It says you could introduce air, something with a low atomic number, gas-producing tablets, crystals, or soda water which contains carbon dioxide. If it says some kind of carbon dioxide crystal, that should just kind of trigger you.
It also said that carbon dioxide is absorbed more rapidly by the body than air.
Okay.
What is an aqueous iodine compound? Is that anything you need to know?
A what?
AQUEOUS, aqueous iodine compound?
No,
I don't need that.
don't need that. You do not need to know the 3 particles for the
Just know
non-ionic.
it's 3.
Know that it's 3. Yep.
This one just says baking soda crystals.
Baking soda crystals, okay. For the negative contrast agent. Baking soda crystals, anything that you could eat or drink that would produce air. So think about something that's going to make fizz.
Carbex granules.
Okay. Word burp, yeah, something that's gonna make you burp, right? That you're not supposed to do. Okay, are we good on that?
Oh, one more, I'm sorry.
You're good?
I struggled with this one. So what about the do we need to know anything about the density factors for like negative and positive contrast stuff?
Go into detail, what do you mean?
Okay, so a negative radiolucent, does it increase the density? Decrease density, like any type of those types of questions?
I wouldn't confuse yourself there. I would know which ones are positive and which ones are negative and what they appear as. So it might say which contrast agent would appear white on an X-ray film.
Okay.
Okay.
I can handle that.
Gastrograph, it doesn't show as brightly as barium, but they want gastrograph because they most likely have a valve
Perforation, right, if you used a water soluble.
So it would be
Yes.
positive.
Barium is your highest atomic number as far as your positive contrast agent, so it's gonna appear the most white.
Okay.
The other ones, I know there's a ton of them listed in the book, IsoView, Gastrograph, and GastroView. I would not focus on memorizing those if you don't know them.
Do we need to know what category, for instance, would gastrograph fall into?
As far as negative or positive?
That's iodinated.
So everything that's positive, that's not barium, is iodinated water soluble.
Say that one more time.
Okay, everything that is not barium, that is considered to be a positive agent, is water soluble.
Okay.
Iodinated.
Okay.
Okay.
Thank you so much.
If it's barium, it is not water soluble. Remember, it's that suspension, it can be separated, it can't be absorbed by the body. Negative contrast agents are kind of solo, air and gas. But all of the other ones, gastrograph and GastroView, IsoView, GastroView, all of the CT agents, they're all iodinated. Iodinated water solubles. Good question.
Thank you so much.
Yep. All right. There's also an oil contrast agent. Did anybody write any of that down? Oil-based. Slowly absorbed.
Do we need to know that?
I would write it down. It's not commonly used and it's slowly absorbed in the body.
What about osmolarity?
Osmolarity. As far as the concentration,
There was a whole section about like viscous.
As a contrast agent increases, the risk of
So
reaction
it's the old
increases as
phase.
well.
sure. Yeah, let's write that down.
What?
Yes, osmolarity. Yeah, I would know that section. Is that in this book?
Yeah. Before that.
Non-ionic,
Correct, yeah.
ionic. Hold on, I'm gonna find it and I'll tell you. All right, I'm just gonna read you what this says, because I think it kind of summarizes it very quickly. Osmolarity as it relates to contrast agents. So this term is related to the concentration of osmotic solution and has a relationship to the patient risk of reaction. As osmolarity of contrast agent increases, so as it goes up, the risk of reaction increases. So if it's more concentrated and more osmolarity positive, it is highly reactive, okay? Ionic solutions have a higher osmolarity associated with them than non-ionic. That's why we have a higher reactivity rate. And then the other term that they use to describe contrast agents is viscosity. You can think of it as stickiness or thickness of the fluid. The thicker or the more concentrated it is, the higher reactivity you would have. So think about the concentration like a Kool-Aid packet. The more Kool-Aid powder that you put in, the darker it's gonna be. That's a concentration linked to osmolarity and viscosity. Everybody feel good with those? Yes, good point.
When you're talking about oil-based, is that just like intrathecal?
Oral routes?
Yeah, the, oil-based contrast, is that like intrathecal?
Not necessarily. Oil-based, we don't use anymore.
Is that what they used to use?
Yes, back in the day, that's what we used to use, but because it drains from your body so slowly, they kind of went away from them. I've never seen them used.
So would it be,
Excuse me.
so would it be positive?
An oil-based would still be positive, yes. Yep, it's just a different substance or consistency. Does anyone have a cough drop?
Yes.
Radio.
I was just about to offer you one.
Thank you so much. So radio.
Oh, great. What is it? No, I just kind of dry spot.
Yeah.
Just drop it. Thank you so much. All right. So let's move on. Appropriateness of contrast media to examination. Patient condition. Example, perforated bowel. We kind of already talked about that, right? So it's not appropriate. There's a contraindication to use barium if you have any kind of bowel perforation. Do you have anything else under patient condition? Maybe shellfish allergy. It's kind of the same thing that we've been talking about though.
I've got a recent biopsy, been on steroids for a long time.
Good, I like it. So specific medication maybe, and if they have recent biopsies of anything, you may have some kind of tissue that's open. So any kind of surgical procedure, like if they come in and they say, yeah, I just had stomach surgery yesterday, we're not gonna give them barium, right? Because they may have some kind of perforation or exposed tissue. All right, next. Patient age and weight under appropriateness of contrast media to examination. I don't think we need to write anything else, okay? Lab values, example, BUN, creatinine, and eGFR. What do we have for this? You should need to know the values for these.
Blood urea nitrogen is between 8 and 25.
We're under laboratory values.
Creatinine is 0.7 to 1.3.
All right, so I would definitely write these down if you don't have these lab values.
And then GFR filtration rate is between 90 and 120.
And also there's a different guidance for Caucasian and African Americans with GFR.
Oh, that's right.
Yes, there is. Dang, I just read a study about that.
0.7 to 1.
Yes, oh, repeat, can you repeat the numbers for me, Mia? Sorry.
Which one?
For
All of them?
all of them.
So BUN is 8 to 25. And then creatinine, did I say?
Crap.
Is 0.7 to 1.3. And then GFR is 90 to 120.
And then the eGFR, what do you have written down for that?
Body size, age, gender, and level.
Good. It's kind of a test measured for kidney function based on the creatinine results, the body size, the age, and the gender.
They also have a website you can go to, like a lot of the techs use, where like you enter all this information in, you mark if they're African American, and then it like
Calculates it
all
for
the-
you?
Yeah.
Okay, that has an easy calculation also for you.
What is the eGFR based on?
It's,
The creatinine results?
yep, the creatinine results, the body size, the age, and the gender.
Okay.
That's your estimated glomerular filtration rate, or eGFR.
Can I read one?
These are really important. Why? Why are these values important to us?
Because these contrasts are passed through the kidneys, and if you have kidney failure, they cannot pass the contrast.
Good. Everybody hear that? Everybody know that? When we give contrast agents, if it's filtered through the kidney and the person is in kidney failure or going through kidney failure or has kidney disease or lowered kidney function, they will not be able to filter this out. Okay, so that's why it's important.
And so that's what the BUN is measuring.
Yep. That is what they are measuring. BUN is blood urea nitrogen. Creatinine is based off of how much creatinine is left in your system after your kidneys function. Yep. Okay, complications and reactions. Local effects, it gives you the example of extravasation, infiltration, and phlebitis. Inflammation of the vein, probably, is that what that was? All right, so what do we have for local effects? Go ahead.
Like local versus toxic, you mean? Or just like the extra cessation?
Just the terms, local effects, yeah.
So for extravasation, I said refers to leakage of a medication or contrast medium from a vein rupture or inadvertent introduction into a tissue outside the vein.
So some kind of leaking throughout the vein, right? Okay. Anything else that we need to know?
For infiltration, I put refers to the diffusion of injected material further into adjacent tissues. So I think it said too, if they have like an IV or a catheter in or whatever, and the skin's getting swollen or like really red and hot, to take it out.
Yes.
And contact like a nurse.
Yeah, so if you have
And
any
apply
kind of
pressure.
swelling, or your patient says, I'm burning, if maybe you flush, you use just a saline flush, and your patient says, I'm burning, or my arm's burning, you probably have some kind of leak, right? So some kind of infiltration, some kind of extravasation. You wanna take the needle out so that it doesn't continue to swell and fill up. And then you wanna stay with the patient while you call for help, so somebody who can assess them, right? Never ever leave a patient after you administer type of contrast to them, any kind of drugs, or any kind of IV, right? So we stay with our patients to keep them safe. Anything else under local effects that we wanna talk about?
I have a quick question. So I was in Floro and there was a patient that was saying that she just had like an upper GI done recently and it was burning her throat. So she asked her doctor about it and they requested that she had something to coat her throat beforehand or something. Have you ever heard? I don't
Burning
remember
of
what
the throat.
happened after that. I wasn't there after the
Burning of the
what
throat
happened,
and
but-
Like pre-medication?
Yeah, it's something.
I don't know. I haven't ever heard of that.
It might have just been the patient. I don't know.
Maybe
But it was just
maybe
very-
they gave him a Valium.
Yeah, okay.
I'm not sure though.
I was curious if that's something you've heard of.
We're using barium?
Yeah, it was just very, I
Interesting.
mean, like I said it out when I was at lunch, so.
Interesting that they would use barium if the patient was experiencing burning. Cause that would make me think that they had some kind of like sore or tear.
Yeah, your esophagus is like
Rupture.
raw.
Maybe
Yeah.
it's just irritated.
Maybe, I'm not sure about that one. Okay, systemic effects, mild, moderate, and severe. What do we have here? Shock, good. So we have our shocks in this section. What is shock?
Failure of circulation in which blood pressure is inadequate to support the oxygen.
Good.
And that would be severe.
Yes. Sorry, I'm still dying up here. What are our types of shock?
Septic, cardiogenic, allergic reaction.
Let's go over each one individually. So septic, what is septic shock?
Massive infection.
Massive infection. Good. Next.
Heart failure.
Cardiogenic. From a heart failure, good. Cardiovascular system failing. What about neurogenic? Brain or spine trauma, right? Brain or spine. And hypovolemic.
External hemorrhage.
Hemorrhage, good, hemorrhage. Can also be associated with burn. Sorry, guys.
Do you want another one?
I still got it.
Oh, okay.
It's not really affecting me. I'm just pushing right through it. Okay. So we talked about our different kinds of shocks.
What about the anaphylactic shock?
Yeah, let's talk about anaphylaxis and allergic reactions. What do we have written down?
Hives.
Hives, good.
It's reaction to foreign protein.
Reaction to
Foreign protein.
foreign protein. Okay. Sounds
Or iodinated medium.
Or iodinated media. I like that. Iodinated media. because those are where the majority of our allergic reactions are gonna occur.
Hives are not life-threatening, but maybe indicated of severe reaction. It's just
Good.
for staff to get a severe.
Okay, when do we document a reaction? Mild, moderate, or severe? Which one? Good. Tricky. I got you though. Alright. Alright, mild, moderate, severe. And how do we distinguish between mild, moderate, and severe? Tell me the difference.
For mild, I put symptoms include flushed appearance, nausea, metallic taste, nasal congestion, a few hives, which is urticaria,
Urticaria, yeah.
and occasional vomiting. And then treatment would include administration of antihistamine or epinephrine for mild.
Alright, good. So vomiting, slightly, metallic taste in the mouth is very common, is mild. Weakness, dizziness, sweating, things like that. Okay, what about a moderate reaction? Good. Tachycardia is gonna be mild for sure, or moderate for sure. Excessive vomiting, larger hives. What else did you say, Kat? What else did you say, Kat? Hives are included in the mild. Larger hives.
Giant hives, excessive hives.
Good. Alright. We're gonna document all of these, and then we move on to the severe reaction. So what do we have for that?
Shock.
Shock, good.
Heart failure, cardiac arrest.
Laryngeal edema, right?
Blood pressure.
Laryngeal edema is probably your most common one for registry question.
That's
Laryngeal
what it is.
edema.
Swelling of the.
Yep, that's when you start swelling and you can't breathe. They'll say, my throat kind of feels tight, or I feel like maybe my tongue is swelling. Call somebody ASAP, right? Probably gonna have to administer something from the crash cart to save their life. So severe reactions, any kind of shock. Make sure you know where your crash cart is. Make sure you know how to administer CPR. You should, we talked about the order of that. Call the cab. And you guys are all CPR certified. All right, emergency medications. Do you guys have a bunch of these written down for medication and indications? I wouldn't spend a lot of time on this. I'm just gonna be honest with you, because there's so many questions they could ask you. And, you know, we're not pharmacy techs and we're not nurses and we don't give any of these medications. We don't even administer the medication if there was a crash cart. I would not spend time memorizing this at all. There's too many questions for maybe one question of your 33.
Is there anything specific you think they'll like?
Like epinephrine.
I put epinephrine.
I would maybe know epinephrine for cardiac arrest and anaphylactic shock. But the other ones are very uncommon. Nitro, angina. I mean, I could develop 40 questions from this.
I think they just wanted to know, it kind of went over some basic ones like nitroglycerin or
There was
whatever.
a question in
and
the lab
epinephrine.
book, and it was Decadron for allergic reaction. I never heard of Decadron. It's not Benadryl, it's not everyday medication, and it was Decadron.
Right.
I think just like how to, like medication to lower heart rate and stuff, just basic stuff.
I really wouldn't spend any time on it. I wouldn't, because the question is too broad. Miss one question and spend the hour that you're gonna spend studying this on this many questions from the procedure section. It's just too many questions. We don't administer the medication. We don't need to categorize it. We don't even know, we know that it's not expired on our crash cart, but we can't give it. We don't diagnose the patient to give it. The physician's gonna be there, you're gonna have a team of people and they're coding, so I just really wouldn't waste your time on it. There's too many possible questions for this. Okay, and the last section, yay, radiographer's response and documentation.
Document everything, no matter how small.
Good, document everything, no matter how small. If you didn't document it, it didn't happen. Anything else? I think we're good there. You guys feel okay?
Where do we document it?
In the chart. Good question.
Like, is there a certain?
So
Form?
they'll give you a subcategory normally of reactions or a notes section. So document everything. Doesn't matter if it's mild, moderate, or severe. If the person tells you they're allergic to something and it wasn't on their chart, I would document that. I would document that you verified allergies before the exam and then after the patient mentioned this. Any kind of symptoms, mild, moderate, or severe, or shock. Time in, time out, all of the details of the exam. Yep.
Okay. Section is safety, is this the 4.4?
Yes. Yep, from safety, I would use that book along with your physics book. Yeah, because this one doesn't go into detail about your physics, or it might be your technique book.
Yeah. That's not due next class, right, because we have the test?
Yeah. No, it's not due next week because we have the test. So next week, your 50 questions for patient care are due at 8:30. And I won't see you. I mean, I might pop in to make sure you're in the assessment center and everything's going good. I'll be on campus. But next week, we will be meeting in the testing assessment center, let's say at 8:50, right? So everybody starts on time. So you're starting at 9 a.m., a minute per question, and it's 200 questions, and you'll be able to review it after.